Thrust through the extended leg. That could upslip or it could posteriorly rotate.
Posterior anomaly.
Asymmetry. Again, for this one, do the same thing as before. Posterior anominate, bony landmarks. PSIS is up or down? Down. ASIS is medial malleolus is in supine, short. Up. Long sitting test, posterior anominate, short supine, short to long, long sit. Muscle hypertonic and or tight, posterior anominate. What's going to posteriorly rotate the anominate? What gets facilitated in tight? Glutes or hamstrings? Hamstring. Usually the hamstring. And then lastly, the muscle you're going to use to correct the impairment will be the hip flexors. What'd you say? All right. So we have two techniques. We're going to do the MET first, and we're going to do one technique in supine and one technique in prone. Let's see, Frank, can I have you come up?
No claps for me. All right, settle down, settle down.
On your back. All right, so posterior, let's say on the left. What's that going to do to hip position? Will posterior rotation internally or externally rotate the hip? You got to look at the alignment of the joint. So when you posteriorly rotate, it's not straight sagittal. There's a little bit of an out flare. So the hip will go into external rotation. So on that side, when I compare, I find a little limitation in internal. That's not a hip problem. That's an anominate problem. Maybe that's why you have hip pain. Maybe because that anominate rotation is affecting the alignment of the hip. All right, so the MET, the muscle energy. Let's see, slide over towards me. I'm going to treat the left side. We want to balance the pelvis. If I keep his leg straight and I bring this hip into extension, then that may anteriorly tilt the pelvis, and I don't have mobility on stability. So remember as a kid, you're in the swing. The swing has to be stable as you move, right? The whole thing, probably the one that I set up for my kids when they were young, the whole thing was just like, that's mobility all over the place, right? So, mobility on stability. So I bring him up here. I'm going to take him up pretty high because if I start low, I may miss it. I want to get the restrictive barrier at its very beginning. So I'm going to palpate the joint with my fingers, medial to the PSIS. Slide over towards me some more. Good. I'm going to take him into hip extension, which will recruit the anominate, and I want to be at the feather edge, the very beginning of motion here. Very beginning of this is now a dysfunction. With you guys, it's probably not, but the patient, you're going to be at the very beginning of the restrictive barrier. That's what we're treating here. We're treating restrictions. In normals, what barrier would that be? If they don't have a restrictive barrier, that would be the elastic barrier. There's the physiologic, active, elastic, passive, anatomic, end of the line. But in a patient, this would be the restrictive barrier, the very first sense of resistance. And now I'm going to use the hip flexors, so don't let me move your knee down to the floor. Meet my force, or I can just use gravity. 1, 2, 3, 4, 5, 6. Relax. Think about the two effects, neurophysiologic and mechanical. Neurophysiologically, we've just done what? We've activated the hip flexors, which reciprocally inhibits the hamstring. Good. And we've also used the hip flexors in reverse action, so the iliopsoas, the rectus femoris, are, with a stable insertion, are pulling the anominate into anterior rotation. Hold. Gravity, good. Relax, get a little lower. And hold, add a little resistance if I want. Less is more, very light with MET. Relax and reassess. Landmarks, standing flexion test, long sitting test. That's one way to do it, on your stomach. Now I'm going to treat, that was the left, we'll still treat the left. I'm going to, mobility on stability, I like this principle, so show it to us on the practical. Let's bring this foot on the floor. Now what if you don't do that? If you forget to do that, and I come in here and correct this, do you see how the whole pelvis is moving? So I want to make sure that only the left side moves on a stable right. So let's stabilize the right by putting his foot on the floor. Bend your knee. Good. So I come in here, add a little bit more stability. Come under here. I'm in the joint. Come up until I feel the beginning of resistance. And ready? Don't let me move you up to the ceiling. Pull down to the table lightly, lightly. 1, 2, 3, 4, 5. Relax. Let it go, let it go. Relocalize. Taking the left innominate against its barrier into anterior rotation on a stable right. New barrier. Don't let me bring you up to the ceiling. Ready? Go. Hold. 1, 2, 3, 4, 5, and relax. Good. 2 or 3 times. Inhibition of the hamstrings, working the innominate in reverse action to anteriorly rotate it. Sometimes I like to ask people, because they get so caught up in the mental gymnastics and the theory, sometimes we miss the obvious. So I may ask you, how far do you want to move it anteriorly, by the way? You'll say, you want to move it anterior because it's stuck posterior. I understand. But how far? What do you want to do? How far do you want to go? How far? What do you mean by how far? Well, do you want to move it all the way to the other extreme? No, I don't want to do that. What am I looking for when I ask that question?
Neutral.
I want to reestablish neutral alignment. Balance it with the other side. Good. All right, thanks, Frank. Now let's try that.